Hello, thank you for having me here today. And thank you for the invitation to speak at your conference. My name is Melissa Ooi. I'm from National University Hospital in Singapore. So 45 minutes I was told I had, not 30 minutes. It's a bit short for relapsed refractory multiple myeloma, but I will try to keep the time. So I have nothing to disclose. So this will be the issues that I'll be covering today: how best to treat relapsed refractory disease, and what are the practical management issues, especially in relation to the new agents, treating extramedullary disease, as well as expecting the unexpected, as I'll show you in a few patient cases. So over the last 15 years, myeloma has really changed. I mean, I remember when I first started training, which was quite some time ago, we had VAD, which is, now VAD is dead, as the paper would say. And the life expectancy for myeloma patients has also extended. Now we can say that myeloma is something akin to a chronic disease. If you have standard risk myeloma, you can expect to live for about 10 years at this point in time. And we also have many new drugs for myeloma. As you know, last year alone we had 4 new drugs approved by the FDA. And myeloma has really changed, but we still have some challenges. There's still no cure for myeloma. There's no good treatment for high-risk disease. And it's great to have all these new drugs, but how do we use these new drugs? What order do we use them in? What are the combinations? That is still things that we do not know. And hopefully, in the next few years, this will become clearer. So you've seen this graph before. Currently myeloma is a relapsing remitting disease. You maybe present with MGUS or smoldering myeloma, and then, you finally get into the active myeloma stage where you get treatment. Most patients would go into remission, and then they will relapse again. You treat them again, they'll go into remission, usually a shorter remission, relapse again, etc., etc. There are a subset of patients who are refractory, they won't go into remission, and these are the patients that usually are quite difficult to treat. So you have 2 cases here. You have a slow asymptomatic relapse, or you have a fast symptomatic relapse. So after induction treatment, consolidation plus minus maintenance, patients will be in some form of remission, either a complete remission, a VGPR, or even just a PR. And then you start monitoring them on a 3-monthly basis, etc. Then you see that the M-band starts to creep up. So if the patient is quite, asymptomatic, they have a slowly, kind of increasing M-band, they have a low tumor burden, the M-band is maybe 2, 3, 2, that sort of thing. If they were cytogenetically low risk at the very start, and they are very fit and well otherwise, you can afford to just watch these patients, closely, but just watch them and not necessarily have to do anything. Now, if the patients have a lot of symptoms, the M-band is going from, like 1 to 10 to 15 on a monthly basis. They have a high tumor burden with a high LDH. They have organ involvement. They have kidney impairment now. They have anemia. If they had cytogenetically high-risk disease at the beginning, they have a poor performance status. They're not very fit. You may elect to treat these patients faster. So really, when and how you treat the patients would really depend on how they present themselves. As what Professor Michael said, is how they phenotypically present their disease. So, as mentioned before, if they relapse within a year, then you may want to, you may indicate that the patient has a resistant type of disease. You may want to change the initial treatment. Let's say if you use Velcade initially, you may want to use lenalidomide. If you had used lenalidomide, you want to use, maybe a proteasome inhibitor. And if you haven't used any novel agents, let's say use VAD or just high-dose dexamethasone, it may be the time to consider it at this point. If they have a late relapse, so they had a good run, they were very well, you can re-challenge with what you've used before. So if you've used Velcade before, you can always use bortezomib again. If you've used, I would say that if you haven't used a novel agent, you should probably consider it at this point. And if the treatment was effective, there's nothing wrong with reusing it. So we try to individualize the treatment of the patients at the relapse. So if they have, we look at their disease. Are they an aggressive disease or a non-aggressive disease? Because that would involve maybe using 3 drugs versus 2 drugs. If they have had peripheral neuropathy from, let's say, thalidomide or from bortezomib, you may not want to use that again because that would make the peripheral neuropathy worse. So you would consider using lenalidomide instead. If they have renal impairment, you would definitely want to use bortezomib because lenalidomide, you have to dose adjust for renal impairment, etc. And we know that bortezomib seems to work quite well with steroids in patients with renal impairment. If they've had venous thrombosis before, you may not want to use lenalidomide or thalidomide because obviously that increases the risk of getting another VTE. So bortezomib may be the choice for them. If they have a low bone marrow reserve, and what I mean by that is that they have a lot of cytopenias. Some patients, no matter how much you dose reduce the drugs, they still become very cytopenic, very anemic, need lots of transfusions. You may not want to give them lenalidomide because that will make them quite myelosuppressed, so you may consider Velcade or thalidomide. And hospital distance, in Singapore that's not really a big deal because everything is half an hour away. But I'm sure in Indonesia, this will be a problem here. So if you are very, very far away, coming in, twice weekly or once weekly, even for injections of bortezomib, may not be something that will suit the patient. So an oral version or an oral tablet, obviously, where they just come for a review once a month, may be something that they would prefer. So as mentioned, we have many, many options, thalidomide, lenalidomide, bortezomib. Obviously, we do know that triplets are better than doublets. We have a combination chemotherapy of old, the DTPase, etc., especially if they have extramedullary disease. And, we can always still consider transplant, be it a second autologous stem cell transplant or a first if they haven't had one before, or even an allogeneic transplant. But again, this one, an allo transplant will be reserved for really the cases where you feel that, they are really bad players. And, we have lots of new treatments now. We have many new proteasome inhibitors, such as carfilzomib, ixazomib, which is all FDA approved now. And then we have your new IMiDs as well, like pomalidomide. And we have pubinistat, which is a HDAC inhibitor. And your monoclonal antibodies, daratumumab, elotuzumab, they're all also FDA approved right now and available for use, maybe not in Indonesia, but available for use. And there are many others currently still in, phase 2 trials, etc., but will probably be coming out in the next few years. And when we talk about immunotherapy, we not only have the monoclonal antibodies, but there's checkpoint inhibitors, there is vaccines, there is CAR therapy, and all these are currently still in trials, but they will be available in the next couple of years. And this is a field to watch out for because I think there's going to be a lot of improvement in myeloma patients, maybe even giving them long remissions with these new therapies. So just to run through a couple of relapse refractory studies, based on the agents I've spoken about, and I won't dwell on this because I know there's been a lot of mention already. So just this couple of studies, the POM-DEX study, Panorama, Endeavor, Tourmaline, which is the ixazomib study, Eloquent, which is the elotuzumab, and then obviously daratumumab. So just to remind everybody, POM-DEX was against high-dose DEX. And you can see there was an improvement in median PFS as well as OS. So there was also not too much toxicity seen in the treatment arm, mainly related to cytopenias, because of the pomalidomide. So that's no real surprise. So the conclusion of the study was that, it works. So that's why pomalidomide is now approved in a relapse refractory setting. So pamidostat was the other study, Panorama 1, which was in patients who've been exposed before to the bortezomib, and it was really it was based on the phase 2 studies, which showed that patients who the subset of patients that did well on the pamidostat was the ones that had Velcade before. So the Panorama 1 was designed with the addition of bortezomib and dexamethasone, and that is the FDA license pamidostat with Velcade and Dex versus Velcade and Dex. And again, they showed that there was an improvement in PFS, and even in patients who've had more than 2 prior lines of treatment, there was an improvement in the treatment arm. So again, the conclusion was that it works, even in patients who had previously been treated before. So for Endeavour, with calcivimab dex versus bortezomib and dex, again, there was an improvement in PFS, and the conclusion was that the treatment arm works, that the new drugs are better than the old drugs. Aspire, which was a combination of calcivimab, lenalidomide, and dex versus lenalidomide and dex, again shows that there was an improvement in PFS and that the new drugs worked, the triplet was better than the doublet. Now, just a caveat, there was quite a lot of adverse events reported in the calcivimab arm, mainly related to cardiovascular events. There was more shortness of breath, heart failures, thrombosis, as well as a few incidents of thrombomicroangiopathy. And overall, I think as more and more people have used calcivimab, we are seeing quite a lot of cardiovascular AEs with this new drug. So if you are going to be using calcivimab, and I will mention it when we go to the practical management part, that these are the few things you need to watch out for. So for ixazomib, which is the oral bortezomib, if you want to call it that, it was tested against Landex and with Landex and ixazomib, and again, it showed that there was an improvement in the median PFS. And looking at the AEs with this drug, there wasn't really very much. The treatment arm reported some, diarrhea, constipation, nausea, etc., but there wasn't a significant amount of 3-4 adverse events in the treatment arm compared to the Landex arm. So overall, quite well tolerated. And the conclusion was that, it works, there wasn't too much toxicity, and, therefore, if you are the drug company for ixazomib, we should give it to everybody. Now, for elotuzumab, again, it tested in the refractory setting in combination with a lenalidomide and dexamethasone, and again, it shows that the treatment arm showed an improvement in progression-free survival compared to the control group. And there, again, most of the most of the adverse events were really related to infusional events. Patients getting hypertension, kind of hives, etc., during the first infusion. And for the second monoclonal antibody, the anti-CD38 antibody, daratumumab, there were two studies, the CASTOR and the POLLUX. So CASTOR was the daratumumab with bortezomib dexamethasone, and POLLUX was with daratumumab, lenalidomide dexamethasone. So they were quite similar in design, just that the backbone was slightly different. And in both studies, really, we showed that there was an improvement. And the main adverse effects, again, were mainly related to infusion. So about 80% of patients had infusional-related events, and it was mainly during the first reaction, and then it kind of went down quite a bit in the second and subsequent infusions. And there's a lot of management, kind that we know of now with infusional-related events that we can patients can actually tolerate subsequent infusions. We know what to do now when they have this problem. And so, we are not too worried about that now. But again, there was no other major toxicity seen with this new monoclonal antibody. Seems to be quite well tolerated other than for the IRRs. So I will just go through one of the patients that I have. His name is MBS, and he was diagnosed initially in January of 2008. So as you can see, there wasn't too much in terms of his cytogenetics, no red flags. His serum free light chain ratio was quite high, it was 14.9. His beta-2 microglobulin was high as well, 8.1. His albumin was okay. His LDH was normal. So it was ISS 3, but at that time there was no revised ISS. But if you kind of looked at the revised ISS, he would be ISS 2 because he didn't have a high LDH and he didn't have any high-risk cytogenetics. We didn't have FISH at that time in 2008. So he had BTD for 3 cycles, and then he had rhabdomyolysis secondary to bortezomib. It was quite bad. He actually got acute kidney injury. His creatinine went up to about 2 milligrams, and he needed, I think he almost needed dialysis, but he managed to escape from it. So obviously the Velcade was stopped at that point. He was given time to recover. He was given steroids, etc. He recovered from the event, and then, because he still had quite a significant monoclonal band, he was put on MPT, because at that time they thought that he was too unwell to go for transplant. So he had MPT for 6 cycles, so that brought us into March of 2009. And he unfortunately had quite bad peripheral neuropathy secondary to thalidomide. I mean, he would complain of a grade 2 neuropathy, no pain, but definitely, bad aesthesia, cannot really feel, kind of bad proprioception, etc. Then he got some other complications related to prophylaxis. We gave him dapsone for the, because he was he wasn't G6PD deficient, but there was some reason, I'm not sure why he wasn't given Bactrim, but he was given dapsone for PCP prophylaxis. He got oxidative hemolysis. But despite all that, he was actually in stringent CR after treatment. And he remained off treatment for 6 years and 8 months. That is a really impressive, time of treatment. But, as all myelomas do, he eventually relapsed, and we saw that as a slow biochemical relapse, and then he became anemic. So he had a repeat marrow done when he relapsed the first time. Again, the cytogenetics, didn't have too much going on, but he had a 414 at that time. He may have had it in the beginning, we just didn't have fish at that time, so we didn't know. He also had anemia and renal impairment. He again, had abnormal free light chain ratio as well as a highish M-band. So we restarted treatment for him. And we had several clinical trials running at that time, so he got onto a clinical trial. So I'll show here. So this was, kind of when he was in his remission, then when he relapsed, he got on to the Tourmaline, Exosomib, dexamethasone trial, which is the MLN trial. Now, we're not sure which arm he was in, but he had a reasonable reduction in his M-band. The reason there were so few numbers here was because it was done centrally and I don't have access to all his numbers. But, he was on the MLN trial for about 14 months before he relapsed. And then there was another trial, so he was on Pomdex at that time. And again, had a good 15-month remission. But you can see over here, he started getting relapse, and when he relapsed, he actually presented mainly with infections. So he had pneumonias, he went to ICU, I think here, he went to ICU here, he went to ICU here, for type 1 respiratory failure. So his main issue when he started relapsing was infections. And then, we had to take him off trial because his M-band went up. And then, so we gave him Calfuzimib, dexamethasone. And he had a reasonable response, but because at that time there was no trials available and Calfuzimib was something he had to pay for, so he couldn't afford to pay for more than 2 cycles. So then I decided to give him some CTD just to buy time because I knew that there was going to be a patient access program coming up for Calfuzimib. So, he didn't respond too well with CTD, and the peripheral neuropathy that he had from before came back again, and, he felt really poorly after 2 cycles of thalidomide 50 milligrams. So once he got approved for the free Calfuzimib, I put him on KCD, and he's had a good response since. So he's on his second cycle now of KCD. I kept the Calfuzimib at 36 milligrams, and who knows what's going to happen. We do have other trials coming up, and so he probably will relapse again at some point, maybe in about another year's time, and then he'll get another trial, and then he may respond again. So this is the typical, you can see, kind of what I've shown in the graph earlier, relapsing, remitting sort of picture. Just keep this graph in mind, and then you will see the next patient and how it contrasts with this next person. So just to remind everybody, you all know this because it was very nicely presented already about the risk stratification. So, if you're high risk, with those bad things for the 17P, 1416, 1420, if you're intermediate with 414, and then if you're standard, you generally do quite well. So again, this is the revised ISS. I don't need to remind people about this, so I'll just skip on to the next patient, TSH. So she was diagnosed in December 2015, and at that time she had, the bad player. She had a 17P as well as a 414. So this one put her into the high risk already. This one is an intermediate. So again, she was ISS 3 because she had a high beta 2, and the revised ISS was 3 because she had both the ISS 3 as well as a 17P deletion. So this was actually her graph So it's not too impressive. She looks like she was doing really well, right? I mean, her M band was consistently going down. So she was diagnosed here. She's about 72 and not, a very robust 72. So I elected her as a non-transplant. So I gave her VMP. Ideally, with a 17P, I would like to give her 2 novel agents, Velcade, bortezomib, as well as lenalidomide. But her family couldn't afford to pay for 2. So between the 2, I picked Velcade. So she had a good response. Her M band was down very nicely and consistently. But around here, her platelets also fell. I didn't put the graph up, but her platelets would be, low initially at presentation, then it went back up to normal, and then it would fall. It was around 20s, around here, and there was no explanation for it. She was very well, she was not septic, but her platelets would be here. And then she started getting all these fevers around here as well, which again, every single workup was done, no identifiable source of infection. So because of the low platelets and this funny fever, I decided to marrow her. And this unfortunately was her bone marrow. So this was her bone marrow at diagnosis, and this was her bone marrow at relapse. So you can see, the marrow at diagnosis was kind of your normal standard plasma cells, but at relapse, they look, they have a multinuclearity, they have a more sort of plasmablastic appearance, so they've kind of changed. So this does not look like the same disease, and certainly we can see that, although, she didn't have an M-band, and her serum free light chain was also quite flat, that, she's obviously relapsed and changed her disease, so there's probably clonal evolution here. So I put her on ixazomib, lenalidomide, dexamethasone, mainly because of cost concerns, and the fact that she didn't want to travel very frequently. She liked the oral version. And she has done reasonably okay so far, although she's still quite thrombocytopenic. So because I cannot use her M-band to track her now, I will have to do a bone marrow in about maybe 3 to 4 cycles if I don't see an improvement in her blood counts, just to know what's going on in terms of her disease. Because at this point, when I marrowed her, her bone marrow trafine was, full of myeloma. There was no normal cells, and that would explain the thrombocytopenia. So this is what we normally do in NUH. We will always give a Velcade containing regimen as our first line. If you are transplant eligible, we would give VTD. If you are transplant ineligible, we would give VMP. And then we would give an IMiD, usually thalidomide. If you can afford it, definitely lenalidomide would be our choice. And then, we would, use back Velcade if they had a good response previously, etc. And then if they relapse through all this, we would consider calcizumab or pomalidomide. And then, vice versa, one or the other. And then an alternate would be, pabinostat in combination with Velcade. And then, really we would use combination chemotherapy like DT-PACE, etc. Now, if there was a clinical trial, we would enroll patients in clinical trials, we may sometimes just give like 1-2 cycles of chemotherapy just to disease control them before we move them on to a sort of a novel agent, especially if they have a very aggressive type disease or they have extramedullary disease, just to get in control of their disease. We would also consider a second transplant or an allo transplant, again, in the patients are fit enough or if we feel that their disease is very aggressive. Now, in the advent of the current era, with all the new meds, daratumumab obviously comes into play now. We don't really know at which point, it will come in, probably around here, but, we can use it anywhere along here as well. And same for elotuzumab. Again, we can use it anywhere along here. And the same for ixazomib. Again, we can use it anywhere along here. So our strategy is, always enroll patients in clinical trial if there was one. If not, then we will just move on according to the line. Sometimes we do get access to free drugs if the company is, in the midst of regulatory approval, and we would try to add that in. So ixazomib currently, when we have availability of free drugs, we would add it to anybody with Landex, just because we know that, ixazomib Landex is better than Landex alone based on the trial. So when we choose treatment for relapse refractory disease, sometimes it's kind of arbitrary, sometimes it depends on the patient's needs. It's also depending on how the patients present in terms of their disease. So there's a lot of factors that influence our decision. So, things like how they tolerate prior therapy. So like my man with bad neuropathy with thalidomide, I really didn't want to give him CTD again, in the relapse setting, but because there was no other choice, I said, let's try it. If you have very bad pain, we will stop it. And true enough, after just 50 milligrams, 1.5 cycles, he said, Doc, I cannot take it anymore. I can't even walk. So we had to stop it. If they've had, prior therapies, if they had good response, again, we would try them back again on the same medication because they've shown that their disease, has responded before in the past. If they had a very long interval since the last therapy, again, we would go back again with the same medicines. If there's certain subtypes, high-risk subtypes, etc., we may be more aggressive up front. If they have, other comorbidities like renal impairment, I may use Velcade, let's say, in place of lenalidomide in patients like that. Again, treatment availability, as you can see, we are quite, promiscuous. If anything's around, we would just give it to the patient because, obviously, like Indonesia, patients have to pay for all these treatments, and so if we can get free drugs, we would just give it to them. And how fit they are as well would play a part. Like the other lady, the second lady who was quite weak and didn't want to come in very much. I would like to give her calcizimib if I could, Landex, but she didn't want. So again, patient factors, patient choice plays a role in this as well. And if they've had previous stem cell transplant, how quickly or how long their remission is after transplant would play a role in, would we recommend a second transplant or even an allogenic transplant in these patients. So managing adverse events. So just very, very briefly, there's a lot of new medications out there, and there's been a lot of management issues with some of these new agents. So as you can see, with pomalidomide, most of the problem is myelosuppression, but we can give G-CSF to support the patients through their myelosuppression part until their bone marrow recovers and kind of makes their own myeloid cells. And with calcizimib, cardiovascular events tend to be a problem. Pamilistat, patients get a lot of diarrhea, and that could probably be related more to dosing. Ixazomib, patients tend to get thrombocytopenia, although like with bortezomib before in the past, it is a transient phenomenon. Daratumumab and elotuzumab both have problems with infusional-related events, as well as some interference in terms of the lab with how we quantify the M-band. So I'll just focus in on these two. So as I mentioned with calcizimib, there are many more cardiovascular events reported now in the literature, as well as there's also a signal that the Aspire trial there was more shortness of breath, congestive heart failure, VTE, as well as some TMA episodes. And in fact, we had a case series of about 4 out of 25 patients. So there's about 25% of our patients actually had TMA. With calcizimib, and we don't know is that an Asian preponderance. We are still looking to do SNPs on these patients, but we are certainly seeing quite a number of them in our own patient population. So the recommendation now is to maybe avoid calcizimib if someone has heart failure. So we do an echo beforehand, make sure that their heart is okay, that the ejection fraction is reasonable. You may want to consider capping a dose if the ejection fraction is borderline. Don't overhydrate the patients, just watch the hydration. In the beginning, if you look at the original papers, they would say do pre and post hydration because of worry about tumor lysis, and I think maybe a lot of the shortness of breath that was part of the adverse events reported was related to actually overhydrating the patients. So patients actually do quite well, and in fact, I've never really seen tumor lysis with the calcizimib crowd. So I think just watching the hydration, making sure that patients don't get overhydrated, especially if they have a borderline EF, would be something to watch out for. And hypertension is another thing. A lot of our patients are elderly and they have other comorbid factors like, hypertension as part of their normal medical problems. So to make sure that, their blood pressure is well controlled, that they don't come into treatment with, systolics of like, 160, 170, uncontrolled blood pressures, etc., would be something to try to minimize any side effects they may have. Obviously, you can always give them Lasix or furosemide if they have shortness of breath or, problems with, dyspnea or congestive cardiac failure. And just be vigilant for TMA. As I said, we are seeing a little bit of preponderance in our crowd of patients, and I don't know if there's an Asian signal, But if you suspect TMA because of thrombocytopenia, maybe their kidneys are going off a little bit, just look at their peripheral blood film. Make sure that there's no schistocytes or something in there that would suggest that they have a microangiopathy. So CD38 monoclonal antibodies are coming, and I know that in Singapore they will get their regulatory license by next year, and I think it may be moving here as well, maybe slower. So one of the three main things that the CD38 antibodies, the adverse events reported mainly are related to infusional-related reactions, interference with the assessment of the M-band, as well as blood typing. So just for the IRRs, so in terms of prevention of IRRs, the main thing is to administer pre-medication. I think in the beginning, this was certainly very scary to a lot of patients, but as we move on and we know a little bit more about how to treat and how to manage, this doesn't seem to be that much of an issue anymore. I think most people are quite comfortable now with managing IRRs compared to maybe at the very beginning when they were seeing a lot of these. It's something like rituximab. In the beginning there was a lot of fear with rituximab, but as we get more used to using it, we don't really get, we're comfortable, and patients are quite, the physicians and the nurses are quite comfortable treating patients now with it. So mainly, the same thing like you would do with rituximab, you would give, steroid, you might give paracetamol, and you give an antihistamine, and then, you may or may not give post-medication steroids on the next first and second day after all the infusions. As I said, most of the time the infusion-related events are the first infusion, and then the numbers go down significantly for the second and subsequent infusions. And I don't have a lot of experience with daratumumab. Unfortunately, we were not involved in any of the clinical trials, but we have used it ad hoc in a number of our Singapore patients, and we don't actually have any infusional-related events at all in less than 10. I will, put it out there, but we have had no infusional-related events at all. So I don't know, maybe we're just more comfortable with it now because it's more reported, there's more reports on how to manage it, or maybe Asian patients don't have, infusional-related events, who knows. But anyway, we haven't seen any in our patient group. So interference with assessment. This is more if you are running a clinical trial or something, because when you're measuring the M-band, the antibody can interfere with the assay that you're running. So, and this applies to any of the monoclonal antibodies. The Elotuzumab will do this as well. So it will be difficult to discern, what is the patient's clonal immunoglobulin versus the antibody itself that you're trying to measure. So daratumumab has come out with this DIRA, the daratumumab immunofixation reflex assay. Essentially, if you incubate the patient's serum with this, it's supposed to show you in the picture, move the M-band up, so then you can actually measure it more properly. So this is the patient, and this is when they have the anti-D, and you can see it's moved up from here. There's another band here. So this is the monoclonal antibody. So this is the real patient's M-band. Same for here, patient's M-band with the monoclonal antibody, and when you incubate it with the DIRA, it's moved the monoclonal antibody up, so you can actually get a more accurate measurement of the M-band. Now again, this is if they are trying to get very, very specific, low-level M-band quantification, which for most of us, if you're not in a clinical trial, it may not be that important. But it would be useful to know from a lab perspective that if you're seeing 1 gram of monoclonal antibody, it could just actually be your monoclonal antibody and not the patient's actual M-band. But this is the more important thing, blood typing. So unfortunately, the CD38 is also present on your red blood cells. And this can interfere with, the daratumumab, when given to patients, can bind to the CD38 on the RBCs. And it is this binding that causes the interference with your IAT. So when you're doing your group and cross, you might get, a positive IAT. And it's, for the lab perspective, it makes them very confused because they won't know, is this a an actual positive antibody, like a allo antibody that the patient may have developed, because obviously our myeloma patients tend to be quite heavily transfused. So one of the strategies is to, do the blood type group and cross with using DTT. DTT is a reagent that will actually just strip off the anti-CD38 from the RBCs, and so it will prevent the DARA from binding to the RBCs. Unfortunately, the DTT will also strip off your CAL antigen. So, you have to, if you do it this method, you will have to give CAL negative red blood cells. The other way is to do genotyping, which is, expensive. And then another way is to do a full phenotyping, which is quite difficult because for patients, if they have been transfused in the last 3 months, your phenotyping may not be accurate. So this is a problem for our blood bank. And first, we have come up with a national strategy. The blood banks will do DTT when they're doing their group and cross. We are supplying CAL negative blood to the patients. And we are also giving patients a tag to say that, they are on Elotuzumab, that their group and cross may not be very accurate, that they need to have CAL negative blood and they need to get DTT, treatment when they're doing a group and cross when the lab is running the group and cross. So far, that has worked, and we've had no, hemolytic reactions. And in fact, most of the hemolysis, there's been no hemolysis observed and no transfusion, problems related to this interference. It's more of a lab issue. And I think, if you educate the patient, if you tell your blood bank staff what you're doing, and you kind of have a strategy in place, that shouldn't be a major problem. And obviously, if it would be good to fully phenotype the patient beforehand, or if you don't have a choice, then maybe to genotype them beforehand, so you know exactly what blood to give them in the event that they need a transfusion. So just briefly on extramedullary myeloma, and it is a difficult disease to treat, and right now there's been no good strategies to treat it. So it can involve anywhere really, skin, soft tissue, your organs, anywhere you can think of, you can get extramedullary disease. It's less common at diagnosis, about 6 to 8%, and more common at relapse. About 30% of patients may have some extramedullary involvement. Usually associated with high-risk, features like a high LDH or high-risk cytogenetics. And it is a bad prognostic marker. So if patients present with extramedullary disease at the beginning, you know that they're not going to do so well. So how you treat them would really depend on where the extramedullary disease is. So, the main thing is to diagnose it. So I think someone mentioned in the previous panel about solitary plasmacytoma. And, if you see someone with, let's say, a solitary plasmacytoma, you want to make sure that that is really the only location, that they don't have disease elsewhere. So you're obliged to, investigate them as best you can. Now, depending on what's available in your hospital or, what imaging facilities you have, you would want to do like an MRI or a PET scan if possible, just to make sure that they don't have disease elsewhere. You need to do all the myeloma screens, so the serum protein electrophoresis, the immunofixation, the light chains, the Ben-Jones protein. Obviously, you're obliged to biopsy to make sure it really is a plasmacytoma or a myeloma. And you may consider doing an echo. Again, this will, if you don't have availability of PET scans, then you may have to do CT scans. If you don't have availability of MRIs, you may have to consider doing something else. So it really depends on what imaging facility you have. But if you can, you should try to make sure that, they don't have disease elsewhere, that their solitary plasmacytoma is really just a solitary plasmacytoma. So just to illustrate the point, we have a patient. She was diagnosed in June of 2014, and her bone marrow showed normal karyotype. Her fish was normal, and she was ISS2, and she was treated with VCD ×4. She went into a VGPR, and she had a stem cell transplant in November of 2014. So about 7 months after the transplant, she came in complaining of headaches. And some foot drop. So she saw the neurologist, they did like nerve conduction studies, didn't find too much. So then we did a PET scan, and the PET scan picked up a breast lesion. because of the headaches, as part of the neurological workup, she had an MRI brain and there was a lesion in the temporal lobe. So we re-investigate her for myeloma. We did a bone marrow. There was nothing. It was clean. We biopsied her breast. It was actually a plasma cell seen in the breast lesion. And then because of the brain thing, we did a CSF, a lumbar puncture and a tap. And there was plasma cells seen on both cytology, and we flowed the CSF and it was confirmed to be clonal plasma cells. But she had no evidence of, kind of disease outside these two areas. The M-band was flat, the serum free light chain was normal. So this was her PET scan that showed the breast lesion. So then she went on to get triple therapy. So we gave her IT, cytarabine, methotrexate, weekly initially. Then when her plasma cells cleared, we tapered down to twice a week, every 2 weeks. We RT'd her brain, the brain lesion. And then after the RT washout, we gave her Landex. So she was actually doing quite well. Her CSF cleared after 3 ITs. Her neurological symptoms improved. That foot drop that she presented gone, no more headaches, doing quite well. And then we did a PET CT to see what was going on with her breast. The lesion disappeared. And so she looked like she was doing pretty well and responding. Unfortunately, in February of 2016, she presented with skin nodules. Initially, just one on her forehead, and then after that, another one coming up on the other side. And she actually would tell you that, with Landex, you have that 7-day break. You have 21 days treatment and you have 7-day break. In that 7 days break, her nodules will get bigger. Then when she goes back on treatment, the nodules get smaller. So she can actually tell you, oh, my nodule is getting bigger when I'm on my week break. So we biopsied the skin nodules, confirming that it's plasmacytoma. And again, when we did this lumbar puncture, there was no more plasma cells seen on the CSF. We did a PET CT when she presented with these nodules, and it showed that, unfortunately now compared to the previous PET, she has all these hotspots in her axial skeleton, as well as in the mediastinum. So she's relapsed again on Landex, and so after a long discussion, we offered her a second transplant. She wasn't very keen, and to be honest, she didn't have a very great run after the first. It was only 7 months, so we didn't think that it would be particularly great either. She was still quite young and quite fit, so we suggested an allogeneic transplant, although, with all the caveats, with transplant-related mortality, and she took the decision that she didn't want to go for it. So because she was still on Landex, we added in Exosomib just to buy some time. We were considering giving her chemotherapy to at least shrink down, reduce some of her disease before we put her on something like Calfizimib. In the meantime, we had radiotherapy. We gave her radiotherapy to control all these nodules that were coming up on her face because it was quite disfiguring for her. But unfortunately, she passed away as treatment progressed. So you can see here, this was her M-band. So after her initial VCD and autologous stem cell transplant, M-band went right down, and the blue is the free light chain ratio. So there's nothing. Even when she relapsed with the breast lesion and the CSF, there was absolutely nothing on her M-band and free light chain. And it only started to creep up a little bit around the time when she had the skin nodules. So, sometimes you can't rely too much on your M-band to pick up relapses, and it's more on the clinical presentation of the patient. So with CNS disease in CNS extramedullary disease, there's no good treatment. Nobody knows what is the best option to give these patients. We do know that, we can help diagnose it by using MRI, CSF analysis, looking at the CSF for flow cytometry, looking even at M-band or serum free light chain in the CSF sample itself. And the main thing is to make sure that the patient doesn't have an infection. The IMiDs, the lenalidomide, glitamide, or pomalidomide, has been shown to work in these cases. Obviously, we know that steroids can penetrate the blood-brain barrier, the dexamethasone. Bendamustine and radiotherapy, again, there will be options to consider. IT chemotherapy isn't great, but we don't have too much to offer, so we still give it anyway. But we do know that myeloma isn't particularly responsive to methotrexate or cytarabine. If you have non-CNS EMD, you can again consider what we've said before, triple induction, give them autologous stem cell transplant if they've had a response before, if they haven't had it before. Consider consolidation and maintenance in these patients if there was the initial presentation, or if they presented at relapse, you would want to certainly give them something quite strong. There has in vitro studies that pabinostat seems to work in for extramedullary disease. And the monoclonal antibodies is certainly, again, something that is said to work in extramedullary disease as well. And if they have like other, molecular abnormalities like BRAF mutation or something, consider a BRAF inhibitor. So, expecting the unexpected, and my time is up, so I'll be very quick about this. It's just a patient case. So CBC, she presented with 2 months of back pain. Again, she had the typical, low back pain, lots of fractures, anemia, some thrombocytopenia. She was IgG kappa with a high serum free light chain ratio, a high normal LDH, and a high M-band at presentation. Her calcium was also high. She had a very high ESR. Her beta-2 was 5.6, and her albumin was 29. So she had a bone marrow done, and it showed that she was normal karyotype, but she had fish which didn't show any kind of real high-risk features. And the skeletal survey just confirmed the compression fracture at T12, T11, and L3. So she had VCD by 2, and then she went for a transplant. She was in VGPR, and then after the transplant, she was put on no maintenance because she didn't want to go on maintenance. She just didn't want to take any more medications. So she relapsed, unfortunately, in day 100. So we didn't even have time to even talk about maintenance, really. She already relapsed. And she relapsed with an M-band of 51, platelet of 7, and a very high LDH at that time. She also fell, and she had a subdural hematoma. And so I started her on Landex, and then I added in Isoximib. So she looked like she was doing pretty well. I'll show you the graph. So she looked like she was doing really well, at her relapse. I think within a cycle, her M-band had dropped, and I think within 2 cycles, her M-band was less than 1 gram. So she got a lot of cytopenias at that point. She was neutropenic, her newts were around 0.8, her platelets were around 70. And so I thought, okay, maybe it was the myelosuppression from the lenalidomide. So I had reduced the dose and then had stopped it and given her a treatment break for a while. But then her M-band started to creep up and her count still remained flat. And so I figured, okay, that was probably not the toxicity from the medication, it's probably from her disease. So going back, so this was her count. So you can see her platelet count went back to normal and then fell. Hemoglobin went to normal and then sort of was okay. And ANC went to normal, well, went to almost normal and then went back down again. But the M-band and the serum free light chain ratio was quite low. And so she had, when the M-band started going up again in June, she had a second relapse. This was on Ixazomib, lenalidomide, and dexamethasone. She complained of more back pain, so we did an MRI, and there was now extramedullary disease in the paraspinal area. So, her disease seemed to have changed again. So we did radiotherapy to T3 to 10, L1 to L5, just mainly for disease control, because these were the areas that the extramedullary myeloma was the biggest, and we were worried about cord compression. And I started her on pomalidomide, calcifimab, and dexamethasone. So this is just her MRI. You can see all the disease in her vertebrae and the extramedullary disease. And so it was around here that we restaged her, started her on calcifimab, pomalidomide, dexamethasone. So she's just had 1 cycle. Very, very difficult to treat her because she constantly is cytopenic. She's platelet and red cell transfusion dependent. She has HLA antibodies to her platelets, so she gets HLA matched platelets. She has a JK antibody, so she gets JK negative red cells. She was recently in with fever again. So this is a lady that, although she didn't have any high-risk features per se at the original diagnosis, she's behaving very, very aggressively, and to be honest, I don't think that she's going to do very well. So in patients like this, looking at her original presentation, is actually quite deceiving because you would think that someone like her will do well. but the fact that she relapsed within 100 days of her autologous stem cell transplant, the fact that, she actually blew through exosome index, and presented with extramedullary disease, these are the features that, we want to sort of catch and, and sort of, be very aggressive with patients like this. And also to manage the expectation of the family and the patient itself. She's certainly very young. She's only 63. Was previously very well. So allogenic transplant is something that was brought up. It may be a discussion again in the future if she remains well. Not right now because she's in a very bad state. But certainly, this will be a patient that you would want to consider if you can manage to get some disease control. So this is just, a very last 2 slides, just kind of, how to pick the drugs that you want to pick. And, mainly you might consider Elotuzumab if they've had response before, or if they were refractory, if they've got adverse features. You may well consider Pemvidutide, if they were had a good response before. You may not want to consider if they had been refractory to bortezomib. And you would consider exosome Blendex if they've had adverse features. You may not want to give it if they've been refractory before to the IMiDs or the proteasome inhibitors. Saying all that, although we have so many drugs around, we still have an unmet need in relapsed refractory multiple myeloma. As you can see, if you are double refractory, you have a very, very poor prognosis, and it's in these patients that we are hoping that all the new drugs, the monoclonal antibodies, etc., will be able to make a difference. Thank you.